Excellent. Well, welcome everybody. I want to personally welcome you to the MedRhythms Videocast series, which is a monthly video series where we talk to world experts in the field of neurology, research, rehabilitation, and music, and discussing all things from digital therapeutics to music and neuroscience and rehabilitation. Each month, we feature a new expert who will provide valuable insight into these important topics. The show is hosted by me, Brian Harris, the co-founder and CEO of MedRhythms. We're a digital therapeutics company focusing at the intersection of neuroscience, technology, and music to build interventions that transform the lives of those living with neurologic injury or disease. If you'd like to learn more about MedRhythms, please visit our website at www.medrhythms.com. And I hope that you'll find today's episode interesting, meaningful, and compelling. And I believe that you will. And today I'd like to introduce our esteemed guest, Dr. Randie Black-Schaffer. Dr. Randie Black-Schaffer is the medical director of the stroke program and director of the Stroke Research and Recovery Institute at Spaulding Rehabilitation Hospital in Boston. She's the associate chief of the Division of Stroke and Neurology in the Department of Physical Medicine and Rehabilitation at Harvard Medical School. Dr. Black-Schaffer is a physiatrist specializing in stroke rehabilitation. She founded the first young adult stroke rehabilitation program in the country, which has been widely copied regionally and nationally. And since coming to Spaulding, has started the Young Adult Stroke Service at Spaulding, Boston, as well as directing the Spaulding Rehabilitation Hospital inpatient stroke program. She led the development of a post-acute pathway for severely affected stroke patients, a vocational rehabilitation protocol for young adult stroke survivors, and most recently, the development of the first wellness program and music ensemble tailored to survivors of stroke in the nation. Dr. Black-Schaffer has authored numerous journal articles and book chapters on aspects of stroke rehabilitation and is frequently invited regionally and nationally to speak on this topic. As a national stroke rehabilitation expert, she chaired the American Academy of Physical Medicine and Rehabilitation Stroke Care Strategic Planning Committee in 2015, and is often called to comment in the media and stroke rehabilitation issues in the news. In 2014, she founded the Spaulding Stroke Research and Rehabilitation Institute, which we're going to talk about today, with goals of fostering stroke recovery research at Spaulding Rehabilitation and neighboring institutions, and developing innovative clinical program for long-term stroke survivors. Dr. Black-Schaffer has been named a Castle Connolly Top Doctor since 2011 and Distinguished Woman in Medicine since 2018, a Boston Magazine Top Doctor since 2016, and we are also honored to have her as part of the MedRhythms Stroke Scientific Advisory Board. So welcome, Randie. It is an honor to have you here today.
Thank you so much, Brian. That was a most effusive introduction.
Well, it's great. It's great to have you. You've been an authority in the field for a long time, and it's great to have the conversation with you. And we're hoping that today, to begin, you could tell us a bit about yourself and the work that you do as medical director of the stroke program at Spaulding and the director of the Stroke Institute.
So I have been at Spaulding for 20 years now, and director of the stroke program for a little over 10 years. And in that capacity, the role is basically to lead and to coordinate a large and quite expert multidisciplinary team, and to keep us all having the same vision of where we're heading for our stroke patients and how best to care for them and what specific medical and or rehab issues we should address at what level of care. We have a really expert team who all have at least as much experience as I have in their respective disciplines. And I think we do a great job in our program. We run about 650 patients through the inpatient stroke program at Spaulding each year, which makes it by far the biggest inpatient program in the New England area. I might also mention, since we're here, that Spaulding is now considered the second best rehab hospital in the country, according to the US News and World Report annual review of hospitals. When I first came to Spaulding, it was number 14. And so it has been very much on the ascendance over the time that I have been at Spaulding. And while I would love to say that change in rank is all entirely due to my influence, it is clearly due to the influence of many, many people who have worked very hard to improve the hospital, to build a new hospital, to make all of the programs areas of excellence. So I think the hospital is in a very good place currently. We are the home of the Harvard PM&R residency, which is now considered the best PM&R residency in the nation. And those residents assist with clinical care, and they get involved in research projects. They interface with people in other hospitals in the Mass General Brigham orbit. And I think they get an excellent educational experience as a result of working at Spaulding.
Yeah, and I think it's interesting to hear you describe sort of the growth of Spaulding's program over the years. And a lot of it, I think, has to do with growing education opportunities, research opportunities, and things like the Stroke Institute. Can you tell us a little bit about that?
Sure. So we were able to start the Stroke Institute 6 years ago now. And the thought was to try to add to the portfolio of what we do for stroke patients beyond the basic inpatient and outpatient rehab programs. So American medicine over the last 25 years has done a great job of improving care for acute stroke with the development of thrombolytic agents, with the development of MRI and other advanced forms of imaging. We now do a very good job of dealing with patients in the first 24, 48 hours after stroke and diagnosing where their stroke is, treating it specifically with intra-arterial clot busting techniques and or intravenous clot busters, dealing with patients' acute medical complications. And then after that, they often come to us at Spaulding, the inpatient rehab site. And they stay with us usually just for 2 to 3 weeks. We are a short-term rehab entity, and patients rarely stay here more than a month. But after that, they're often not fully recovered. So they then may go on to a subacute or a skilled nursing facility level rehab for another month or two until they're ready to go home. And that care is also usually pretty well defined. The short-term skilled nursing rehab often provides 5 days a week of therapies for them as well, although they're frequently not as intense. And then once somebody gets home, they typically have home care therapies for a couple of weeks to get them acclimated to their new environment. And then they may go to an outpatient setting to continue therapy another 2 to 3 days a week. And that phase can go on for another 2, 3, 4 months until finally they get discharged from outpatient therapy. And that's the end of that first episode of stroke care at that point. And that's pretty much where the medical system says, okay, bye-bye, you're done. Ride off into the sunset and live happily ever after. And there is no expectation in the system that you will need more services or you will need repetitive bouts of therapy. But in fact, many patients do. So the clinical mission of our Stroke Institute is to try to provide long-term follow-up for stroke patients so that we can catch secondary complications that may develop related to the stroke and treat them either medically or with additional PTOT and speech therapy. And also to provide long-term programming for survivors so that when they're done with therapy, they are not just sitting around their houses watching TV forever thereafter, but they have options of community-based activities and groups to become involved in. And with that in mind, we've developed several programs. One is the wellness program that we run twice a year, which is a series of interactive discussions with a lifestyle coach, Dr. Beth Frades, who also happens to be a physiatrist, and she's a graduate of our program here. And she does a wonderful job of giving patients the tools to manage their diet, their exercise, their sleep issues, their stress issues, their creativity, their community involvement, all of those things. And that has been a very successful program over the last many years. Second thing that we started was what we call the Brain Music Workshop, which Brian knows about because he was a music therapist who led the first session of that several years ago now, to great effect. And that's basically an opportunity for stroke survivors to experience social interaction, to experience motor activity and the potential for more exercise to improve motor recovery by playing instruments. And it's an opportunity to experience the benefits that music may provide in terms of coordinated contractions of muscles to help improve coordination and dexterity in the affected extremities, and also the cognitive and memory benefits that are well established by a number of studies now to be afforded people who spend time doing music activities. And that group has been going on for 3 or 4 years now at this point. And this year, like everything else, we're doing it on Zoom. So it is evolved into more of a let's compose a piece of music kind of activity, because you can't really all play instruments together on Zoom unless you have a coordinator to record all the voices separately. But we hope to get back to doing that as an in-person performance activity next fall. We do other things to try to provide stroke survivors with support. We have a closed Facebook group called Spaulding Stroke Survivors, which now has, I don't know how many, quite a few hundred members, around 600 members, I believe, and typically has active conversations, excuse me, among members who share stories and opportunities and new things they hear about with each other. We, in addition, once a year, we run an intensive aphasia program, which provides people with lingering expressive aphasia the opportunity to get a lot of practice with speech. Again, often using the music therapy technique of melodic intonation therapy as part of the curriculum. And that program has been quite successful over the last several years. That's a collaboration with the MGH Institute for Health Professions, which conveniently is located just down the street from Spaulding. And so a number of their students and professors assist in this program with our patients. We've also participated in summer stroke camps with the Stroke Camp organization that organizes weekends for stroke patients around the country. We've done paint nights for stroke survivors. And we're always looking for new ideas. And I think rhythmic auditory stimulation is going to give us some good ideas for exercise groups for stroke patients once we can all get outside together and walk around.
Excellent.
There's a lovely pier that's about a quarter-mile walk outside of Spaulding Rehab Hospital, and on a good day, that would be a great place for people to go with their RAS devices and practice their gait patterns.
Yeah, I love that idea, Randie. And it's interesting to hear you talk about sort of the need for the Stroke Institute, you know, a lot primarily because there's a need for support along the stroke journey months after their stroke incident happens. And in many cases, as we know, when they enter that phase where they're sort of phased out of physical therapy services, we call that phase when they enter the chronic phase of stroke. And while we would like to think that everybody's deficits are gone at that point, you know, that they're back to the way that they were functioning pre-stroke, we know very well that that's not the case. That people have ongoing deficits and there's a need for that support. And I think we'll dive into that topic a little bit here in a moment. Could you tell us just personally a little bit about your music background? You know, you're a performer as well. What does that look like for you?
So I think people who are interested in applying music to this kind of situation, stroke therapy, tend to be people who have been doing music as recreation during their lives. I suspect very few tone deaf persons who are doctors would get into the music therapy thing, but nonetheless, I started out as a child. I wanted to be a classical pianist. And this was a result of watching the Moscow piano competition that Van Cliburn famously won in the late 1950s, and becoming enamored of the idea of playing a piano concerto. So I practiced a lot of piano until my mid-teens, when I discovered that being left-handed, I just couldn't play things fast enough with my right hand to fit the demands of some of the concerti and the various sonatas by Chopin and the like. And so at that point, I decided, nope, I'm not going to go that route, and went off and majored in history instead in college, but then decided to do medicine. But all the time, I did a lot of singing. I was in a handbell choir. I took serious singing lessons for a couple of years. I became a church soloist and sang most of the classical sacred repertoire at one time or another. I more recently took cello lessons for a few years because I wanted to learn how to play the cello suites, entirely due to listening to Yo-Yo Ma's first two versions of the cello suites on CD. And I got through the first one, so I could play the whole first thing. Not well, but I could play it. And then while I was trying to learn the prelude to the second, which was the piece I really wanted to learn, I developed a really bad trigger finger. And it took a year for that to finally calm down. And at that point, I kind of moved on. So I have not played a lot of cello since then. But that was a fun experiment in playing an instrument that does not have defined tones. And also somewhat frustrating to figure out how to land in exactly the right place of each string for every note.
Yes.
I came to the conclusion that I was probably a little too old to get that. I suspect you have to be young to develop that finger sense of pitch.
Yeah, it's interesting as a recovering violist here, which was my first instrument. I can relate to that, and I always believe that it's never too late to learn an instrument. It gets harder as you get older, and I think some of that is because of your perception of how not good you sound. You actually understand how difficult these things are as we get older. But
you may be right. I always used to think I was slightly off pitch, and my piano teacher would say, "No, you're fine. Keep going."
Just keep going. You got to keep pushing through.
Yes.
Well, that's great. Well, thank you for the background. And, I think we're going to connect some dots here in a moment. But for the listeners out there that may not have ever heard what a physiatrist is before, could you just give a little context to the role of a physiatrist in the patient's journey post-stroke?
So a physiatrist is a specialist in physical medicine and rehabilitation. And physiatrists tend either to do musculoskeletal and sports medicine, or they do neurologic rehab, which involves usually an inpatient setting of helping people to recover from an insult such as a stroke, or a head injury, or a spinal cord injury, or an episode of multiple sclerosis, things of that sort. And so I have always been a neurologic rehab kind of doctor. And what we do is supervise the therapy program. We evaluate and prescribe braces and wheelchairs and assistive walking devices like canes and walkers for people. We identify and manage spasticity when it develops, which is a problem people get after stroke or any of those events where the muscles contract in an uncoordinated and not helpful way. And they become stiff and more difficult to move. And there are a variety of types of treatment for that situation. And it often requires lifelong periodic interventions to manage people's spasticity after one of these neurologic events. So we manage those things. We manage pain syndromes that arise out of stroke. And we manage in the inpatient setting at our hospital. We do the medical management as well of all the other medical problems that people have, their diabetes, their hypertension, their heart disease. And that job has become much easier at Spaulding since the development of secure email, because we have a frequent email traffic back and forth to the referring hospitals at Mass General and the Brigham about when we have questions about what needs to happen with individual patients with regard to their various medical issues. I think as a result of that secure connection and the responsiveness of the doctors at MGH and the Brigham, we're able to deliver extremely good medical care for these patients who come to us for their rehab phase of care.
Excellent. Well, thank you for the context. And I want to dive in a bit now to thinking about some of those chronic stroke needs, as you mentioned, and you did mention about the need for patients to improve their walking. And we know that this is a prevalent problem, that oftentimes patients have, about 50% of stroke survivors are left with walking deficits, even into that chronic phase of recovery. And we see that these deficits can be present for weeks, for months, sometimes even years into the future. And it may seem like a crazy question, but from your perspective as a physiatrist, as a doctor treating these patients, is that an important problem for them to fix? Why is walking important? It may seem sort of obvious, but what do you hear from patients about why improving their walking ability is important to them?
I think all patients essentially would like to become community ambulators, be able to walk around their community, go shopping without worrying about how long they're going to be able to walk. So I think that is a basic driver. From the doctor's standpoint, a basic driver is trying to get them to exercise to maintain cardiovascular fitness and also to avoid becoming overweight, which is a very common problem in patients who are relatively immobile after a stroke and just don't exercise anything like as much as they did prior to the stroke. So to get people out exercising regularly in a safe way is an extremely important goal for long-term stroke survivors. And if they can do it in a group, that's even better because they get some social support and some group connection by doing that. But all of the national guidelines from the American Stroke Association support the idea of ongoing regular exercise for stroke survivors within the limits of their medical conditions.
Sure.
And sometimes those are significant because the same people who have a stroke often have cardiac disease too.
Right. So there's sort of, it seems, two prongs. Is that one is it's about independence, right? From a user perspective, it's about them being able to, as you mentioned, community ambulation, to be out in the community, to be able to shop, to be able to walk with their family, with their kids, et cetera. But then also from a prescriber's perspective, it's about managing sort of upstream down the road, prevention of, or keeping people healthy, prevention of unhealthy lifestyles, of obesity, of good heart health.
Well, and also there's the potential to prevent some of the secondary complications of having a stroke. Like I've had a number of patients who, because they lean very heavily on a cane in one hand after the stroke, because they feel they need the support, have developed carpal tunnel syndrome in that hand, for example. Or sometimes people get an ulnar nerve palsy at the elbow from that kind of overuse of the unaffected extremity. So part of it is you have to try to be careful to prevent overuse injuries from the unaffected extremities as well. And my hope is that some stroke patients anyway will be able to improve their gait enough using rhythmic auditory stimulation techniques that they can get rid of the cane and walk on level surfaces at least without needing a device, because that will help to improve their balance, and it will tend to reduce the development of these problems on the good side, which then becomes overused after a stroke.
Right.
People develop arthritis in the unaffected hip for the same sort of reason. They're just leaning on it all the time after the stroke.
Right. No, that's a good point. And it's interesting, as we think about from a MedRhythms perspective, we are building a digital therapeutic to do rhythmic auditory stimulation to help, and we're focusing at the beginning in chronic stroke. And, as you know, we were granted breakthrough designation by the FDA a few months ago for our product based upon its potential to meet an area of high unmet need, which is in chronic stroke. And as you know, we do a sort of our market analysis of this. There's about 3.5 million people in the US alone that have chronic stroke walking deficits. And as you look at the landscape there's really not anything on the market to be able to help these folks to improve their walking. When patients come in and you're seeing them in their chronic stroke journey, do you find that they're telling you a lot about their difficulties in walking? And are they looking for solutions? Are they trying to find things to help them? And what are they seeing there?
So mostly what I hear about is the endpoint of difficulty in walking, like how many falls they've had in the last month or two, and what were the circumstances of those falls. Which are usually not when they're just walking straight on a level surface. It's usually when they try to get up and turn around quickly without thinking about it, that sort of thing. So it's as much a matter of balance as anything. And I think patients will also complain that they feel that they just can't exercise and would like to. They realize exercise is good for you. I think those are important points.
Yeah, absolutely. Absolutely.
And I would like to say that I think that the idea of the use of rhythm and melody is potentially an important modality, not just for walking, for rhythmic auditory stimulation and walking, but for upper extremity rehab as well. And I think the state of therapy devices for that is perhaps not as commercialized yet as the walking situation. But it really strikes me that it's about time that music-based therapies move into the mainstream of therapy and become not the only, but one of the modalities that PTs use, that OTs use when they are working to help patients get stronger again after a stroke.
Yeah,
so
and
I hope you will go on to develop something for arm recovery too.
Maybe it's in the future, Randie. Maybe it's in the future, but I very much align with this. That I think that music-based interventions need to become standard of care, and we now have the research to support how this works from a neuroscience perspective, about how it can be applied very clearly and objectively to movement-based interventions, whether that's walking, upper extremity, et cetera. There's a solid foundation of research that supports that this works. And now it's, I think, collaboration with industry, academia, healthcare to figure out how do we bring these solutions to market and to patients. And that's a very important point. And if we dive into, oh, go ahead.
I don't think it's even important that the music interventions have to be shown to be superior to conventional care. I think equivalence and non-inferiority would be a great place to be, so that you could then use these interventions as an alternative to the conventional treatments for some patients for whom they are more natural or they make more sense. But I think it would be important, unless the neurologic music therapy community expands dramatically very quickly, that some of these techniques be adopted by other groups of therapists as well.
Correct. Yeah, I mean, that's the beauty of the work, is that there's strong work that supports it, but there's simply not enough people to supply them. As you know, there's not many neurologic music therapists trained in the world to really meet the need that we're seeing every day. I mean, and so that's one, is enabling other clinicians to implement these interventions. And how do you enable them? You know, one of the ways to do that is actually through technology, you know, like those that we're building. And as we think about the product that we're building for improving walking post-stroke, utilizing rhythmic auditory stimulation, which we've mentioned today. From your perspective, you know, what does the literature say about rhythmic auditory stimulation in post-stroke rehab? And, you know, what has been your experience with it? And, you know, what type of functional outcomes can it improve?
Well, it can clearly improve gait speed. It also improves gait symmetry. I don't believe there has been a study in the literature yet to determine whether it has an impact on falls or not, but I think there should be such a study, certainly a fairly high-powered study that could really answer that question. I know that Dr. Tout did a study with patients with Parkinson's disease, which showed a clear-cut effect and reduction of falls in that group. I suspect it's a little harder in stroke patients because I think they probably don't fall as frequently as Parkinson's patients do. So you might have to run a longer study with more people in it to see that there's an effect. But from what I have seen of patients using RAS to walk, it really does look like it improves balance. And it should therefore reduce fall risk, which is a big measure in US healthcare these days. I mean, that is something that we are all really striving to do. And that also suggests that if it does reduce fall risk, that this would be a great intervention for the healthy, well elderly, as well as for people with neurologic disorders,
yes,
to help older people maintain their balance and their ability to get around the community.
Absolutely. And I think you bring up an important point there, which is thinking about, you know, the correlates to falls. We know that's an important endpoint, as you said, to doctors, to patients, certainly to payers as well, about thinking about the value of if we can prevent falls. And we know from literature in biomechanics that gait speed and gait variability, so deficits in gait speed and deficits in variability, are two things that are most highly linked to fall risk and to people actually falling. And those are the two things that we're primarily addressing with rhythmic auditory stimulation. So if we could improve speed and variability, could we then reduce falls? And I think it's an important, you know, study that should be done as we think about stroke care as well, to actually show that true connection between those two pieces. But, you know, like you said as well, we are also leveraging through rhythmic auditory stimulation very sort of universal objective measures of music perception and production in humans. So regardless of deficit, so whether that's Parkinson's disease, MS, stroke care, and in fact, even, you know, neurologically healthy individuals, or those that we would think would be healthy aging, that there's a potential here that rhythmic auditory stimulation could really make an important impact in potentially helping those frail or elderly patients to reduce the number of falls as well.
Well, and another target, particularly in the stroke population, is osteoporosis, which very much tends to occur in the unused, affected lower extremity after someone has had a stroke for a year or two and isn't walking around much or using that leg. And if you could just get people to walk more and spend more time weight bearing on the affected side, you could probably reduce osteoporosis and fragility fractures from that situation.
Right.
And that's true of the well elderly as well.
Right. No, that's good context there.
You can get people to add weights to their ankles when they're using their device and they're walking around the community.
Yes, absolutely. I like the idea of that. Here's the product and here's 5-pound weights, one for each ankle, and go for a walk.
Yes.
No, that's fantastic. And, you know, I think the other part of this is, you know, we use this term digital therapeutics, right? Which is really a new asset class in healthcare. So thinking about how software can be used as an intervention in care. And we're seeing across the, throughout our research and throughout some of our colleagues' research, other digital therapeutics companies, for the potential to achieve drug-like outcomes with some of these interventions. And I know specifically for our colleagues in digital therapeutics, one of the questions in a new industry like this is, will doctors prescribe a new asset class? Will they prescribe software as a therapeutic? Would they prescribe digital therapeutics? And I guess, from a physiatrist perspective, are you open to the idea of actual prescribing a device like a digital therapeutic? And what sort of inputs or what would make you feel comfortable with actually prescribing a new product like this?
So the model for physiatrists prescribing medical equipment for patients usually involves a therapist trying the equipment out with the patient first, and or evaluating the patient and saying, yes, this is exactly the device that this patient needs. Here, doctor, would you prescribe it? And I think some of that is true for the Stride Plus as well. I think in some cases I would be reluctant to take a patient who, say, has a left hemiparesis and some visual spatial neglect, who says, hey, doc, I want a Stride Plus. I want to walk around my neighborhood, and just go ahead and prescribe it, because I would be afraid that he would walk into stuff in his left, or he'd fall off a curb or things like that. So I would feel more comfortable if he were assessed by a therapist using this device first. And the therapist felt that, yeah, he's pretty good. He won't have problems with it. Certainly some patients I won't feel need that kind of evaluation, but a fair number in the post-stroke community have deficits that they're not fully aware of, that could be tricky when they get out in the community and start walking fairly fast.
Certainly. And when you think about, obviously I think this is the importance of, as we think about going through FDA and FDA approval, why we needed to have a prescription product, right? That's fundamentally why they need to be prescription, is so that they're under the purview of a doctor, whether that, or a clinician, we'll say, whether that's a PT or a doctor, to be able to make those assessments about who's appropriate and who's not for safety concerns. When you think about the specific products themselves, how would you evaluate whether there was enough evidence? Is there an evidence threshold that you would need to see in terms of published articles, or is the FDA approval of a product good enough for you to feel comfortable, or would you want to look at side effects, or how would you evaluate the product itself and its applicability, or your willingness to want to prescribe it to a patient?
FDA approval is certainly a big piece. I think at least one good-sized RCT published in a fairly high-impact journal would be extremely helpful to convince me that the therapy was effective and not likely to have serious harm. Of course, that depends on exactly what the RCT measures. They may not even look at side effects, or they may. But that would certainly be helpful. I mean, most of the literature in RAS now is quite small studies, right? They're 20, 30, 40 patients, often divided into a control group and a treatment group.
Right.
I think something somewhat more robust than that in terms of numbers of subjects would be really helpful to convince physicians that this is a good thing.
Excellent. Well,
the other thing that would be helpful, very helpful, is if the physician gets some kind of report or some kind of feedback from the patient's device periodically to see, number one, if they're using it, and number two, what their usage looks like and what their parameters look like over time.
Excellent. No, that's good feedback. And thinking about, obviously, if you're prescribing it, it's under your purview.
Right.
How do you know that they use it? How do you know that it's working? Right. Getting some of that, closing that loop a bit with the physician. So that's a good input there, Randie. And I guess as we're coming up towards the end of our time here, one thing that I wanted to ask about as we come towards the ending here is unrelated really to rhythmic auditory stimulation, but I think it'd be interesting for you to talk about the connection that Spaulding, but specifically that you have with the Boston Pops, and what happens every year in the fall, or I guess not the fall, in the winter around Christmas time for the patients at Spaulding.
Yes. So somewhat over 10 years ago, we had a patient at Spaulding who was a member of the Pops, percussionist at the Pops. And he really appreciated his experience at Spaulding, and he, much more than most people, really wanted to come back and to give back. And he arranged, I think, the following Christmas for Keith Lockhart and a brass quartet from the Pops to come over and give us a short Christmas concert, which they did. And I put together a small choir to sing along with them, which we did. And that began this tradition, which went on for 10 years up until this past year when we couldn't do it because of the pandemic. And it gradually increased in size over the years to the point where the last year we did it, I think we had 25 members of the Pops, plus Keith Lockhart, plus about 25 people in our chorus, which we now dub the Spaulding Tabernacle Choir, in order to make those people in out west feel that they have competition. And it's been a really great event. I mean, people get really excited about doing it. We have a number of former stroke patients who participate in the chorus, along with staff members who are pretty much the other people in it. And a few years ago, the Pops began to trust us with their arrangements of tunes that they give to the Tanglewood Festival chorus to sing with them at the Holiday Pops. So we kind of had to scramble to learn those things.
Yeah.
We kind of had to scramble these sopranos to sing the high B flats at the end of some of them. Mm-hmm. But we did it. We didn't sound bad. We sounded okay.
Yeah, it's amazing to think about having such a world-renowned organization as the Boston Pops. I mean, particularly for people who live in Boston, who may, want their entire lives to go and actually see a live performance, and here they are in the hospital, and you've got, a large majority of the Pops performing right in front of you, and you're interacting with Keith Lockhart. He's such a wonderful sport when he comes every year, and his interaction with patients, and what a special gift really to be able to bring to the patients in the hospital, and the firepower that they bring into the therapy gym as they're blasting away these Christmas tunes is just wonderful to watch.
Well, and their first trumpet, Terry Severson, came every year, and he's an amazing musician.
Sure is.
But they're all amazing musicians. And a number of their musicians also have been guest musicians for our brain music workshop over several years. And they would come and demonstrate and play their instrument and assist with the whole group making music for the session that they were there. And Pat Hollenbeck facilitated that happening as well, which was great. He's been a wonderful friend to musical activities at Spaulding.
Right. The wonderful ways that, music and healthcare can overlap, in those ways, and supporting the community and giving, brightness to the patients. And then we think about the other end of that spectrum, which is really leveraging the underlying neuroscience of it, and how do we actually help it to improve functional outcomes. Well, for my last question, Randie, what is the future of research look like in terms of music and stroke rehabilitation? What are the next questions that need to be answered?
Well, I've been very impressed looking into the literature on this with the extent and the number of research teams that have been producing paper after paper in different aspects of this. And so I'm quite hopeful that we'll get some finished products pretty soon. And I'm particularly interested in people developing a standardizable upper extremity strengthening product that involves the use of music. There are several out there at the moment. I think once we get to a point where the hospital can buy a kit of percussion instruments and have them available for patients to use in group settings, and where the OTs know exactly how to help patients to play individual instruments with their affected hand, I think that's key. Then we'll have truly another modality of training to help improve dexterity and movement in the affected upper extremity. And that's variable. That really depends on the OT's comfort level with using these devices. And some people are really into music and they think it's cool, and other people are not so much into music.
Right. We need music, and we need technology to enable it so that everybody has access to it. Yes. Well, Randie, thank you so much for being with us today. And I really appreciate your time and your insight. And as we think about the future of this video cast, as a reminder, we do this on a monthly basis. We'll have another exciting guest, world expert, announced in the coming weeks for our March episode. And if you want to watch this episode again, or learn more about this work, please check out the MedRhythms website, the Spaulding website, and the Stroke Institute website as well. And you can see this recorded video on the website at MedRhythms in the future also. So thanks again, Randie. Thank you all for watching, and we'll see you again soon.
Thank you so much.